Welcome everyone to Spine Conference. Today's discussion is not really specific to the spine, but is wound healing, and it's something that we deal with every single day. So, to get to perform surgery, we have to cut the skin, and to get to where we want to be, usually. And the question is, what does skin do? So, skin protects us from the environment, so it protects us from bacteria. It gives us sensation, so we can feel where we are in our environment. It thermoregulates, it can change our temperature, so when we're running, we're overheated. We let off, we cool ourselves off by perspiring, and then the capillaries dilate, and then the blood that's on the exterior of the skin cools off, and that goes to the rest of your body. The skin lets us evaporate, also store and synthesize things. Can you think of, Aaron, something that's stored in skin? When we cut these big people, what's the first thing we see? Fat, right? So we can store energy in our skin. Isn't that amazing? And it can synthesize things like vitamin D. Absorb, we don't really absorb that much, although the epidermis absorbs oxygen. But some animals, like frogs, can absorb things through their skin. And also, it's a resistance to water and osmosis. So if we didn't have skin, think about burn patients. If we didn't have skin, we lose all of our electrolytes. It's a disaster. So skin is very important. Now, when we make a skin incision, David, you use Langer lines when we used to do skin incisions?
Correct.
So Langer lines, what are Langer lines? Have you heard of them, Aaron, before?
I've heard of them. I'm not familiar.
So I looked it up. I didn't know where it came from, but Carl Langer was an anatomist. A lot of his time was in Vienna, 1819 to 1887. What did he do? He took cadavers and he took what was basically a circular ice pick. It was like a circle, and he stabbed the cadavers with this circular pick, and then he looked at the defect that was left in the skin after he stuck it. Like, he took it out and he looked at the defect, and instead of being a circle, it was a slight ellipse. So he sort of elongated. So he connected the longitudinal line from all these ellipses that he had created in these dead cadavers, and he found that there was these lines that you could create, and these lines corresponded to the alignment of collagen within the dermis. So this is how our skin is lined up. This is how collagen is lined up, and it probably has something to do with how we were created in utero and maybe the way we move. So if you can, when you make skin incisions, if you can go along these lines, it heals very nicely because it goes along the alignment of the collagen. And this is his textbook. You can buy this textbook right now on Amazon for 20 pounds if you want to buy it, Aaron. David. So wounds. Here's a wound, a shoulder wound. They can be clean, contaminated, and dirty. So clean is basically what we do. No organisms, it's clean, there's no bacteria there, basically shouldn't be any bacteria. Clean contaminated is, say, something like respiratory. Or David, do you want to make any comments on clean contaminated and contaminated?
Not really. Not.
So contaminated is like bowel, like
Yeah,
if
bowel.
you, a
Yeah.
bowel
Yeah.
resection, and you have spillage of
Enter a cavity where there are bacteria.
yeah, so you cut the bowel and then you have gross spillage into the wound. Clean contaminated is maybe a clean bowel case or a respiratory case, and dirty is, obviously a very contaminated wound. And wounds, they heal over some time. These are patients I saw in the clinic on Monday. Aaron, you asked me why I was taking pictures of people. Here's one man at a year. It's very smooth, it's contracted. You can still see the scar though. And here's a wound at 3 months, and this one healed by secondary intention. So I want to show everyone a video now of what we're doing. Hold on. So what is a wound? So this it's yellow because we use an ioderm cover for skin, and you use a sharp knife obviously because you want a very clean cut that's 90 degrees to the skin edge. So the skin edge should be a very nice clean cut, and I like to go into the fat so I don't have to worry about injuring anything, unlike an abdomen. And the first thing when you cut the skin, what happens, Aaron?
Well, it bleeds, and
It
like you said, there's fat.
it bleeds, yeah. So you could see just below the dermis area, we get right down to the fat, and in the dermis area, there's a lot of blood vessels. So and you can see they're even spouting. And the first thing we do is we stop the bleeding because we want to be able to see what we're doing. But if let's say there was no doctor there and you got the skin was incised, the body would naturally want to do what? Like
It would
clot.
clot.
Yeah. So all these usually what happens when you cut the skin, it clots off by itself. But we sort of bring that along a little quicker using electric cautery. So we're cutting and this is just below the dermis is fat, and that's the subcutaneous area. And within the subcutaneous area, there's a lot of blood vessels. And this is a cerebellar retractor. It's a very common retractor we use. It pushes apart the skin. Now, I don't like to use these retractors a lot, right, Aaron? I always pull them out. I was like, let's not use the retractor if we don't need to, because I feel that using all these retractors causes trauma to the skin and death of the epithelial or the fat cells. And then once we get past the fat, see, I'm feeling there. Once we get past the fat, I'm feeling for the posterior spinous processes to know where I am. And I pull away a little bit of fat so I can see the fascia. So this is the bottom of the wound, basically. Not the very bottom, but the bottom of the superficial area of the fascia. So our goal is that incision, we have to get that incision to heal somehow. All right, back to our session. So skin is made up of the incision that we made. Remember, we started on the outside and we went all the way down to the fascia. So it's made up of a bunch of layers. And below the fascia is muscle. And below the muscle is usually bone. So the layers, the very, very top is the keratin layer, the cover of the skin, and then the epidermis. And beneath that is the dermis area. And within the dermis, there are a lot of fibroblasts and cells. And within the dermis are the nerves, are there are blood vessels. You see these little capillaries going in, they're blood vessels. There's hair, follicles, sweat glands. Below the dermis is the fat layer. So below the, oh shoot, it stopped. Did it stop? Okay. Below the, here's the epithelium, the basement membrane. So, like we said, there's fibroblasts, there's macrophages, mast cells, there's collagen, fat. So how do wounds heal? Well, the first thing that wounds heal is hemostasis. So we have to stop the bleeding. And then for a couple days, there's inflammation of the wound. And I think that's why, good morning, Doug. I think that's why sometimes patients hurt more the next couple days because the wound gets inflamed. And then you get proliferation of the wound, the fibroblasts start grow, and then it matures and models over the course of months. So the first step in the first couple minutes is you just have to stop the bleeding. So vasoconstricts and all sorts of factors come out, and there's a clot in the wound, and then things dilate. And then you have an inflammatory process that lasts usually a couple days. In an inflammatory process, there are poly-PMNs, macrophages. And then over the course of 2 or 3 weeks, you get fibroplasia. The fibroblasts grow, proliferate, come to the wound, and then start laying down collagen. And then as the wound matures over the next couple weeks, blood vessels grow into it. And then over the course of months or years, the whole thing contracts and matures and creates scar. Now, you may say, why is this scar? Why doesn't the skin grow back? Well, there's only 2 things in our body that grows back, that regenerates: the liver and bone. Bone regenerates completely, and liver regenerates completely. And I remember that because Prometheus was a titan in ancient Greek mythology. And Zeus punished him by tying him to a rock on a mountain, and every day a hawk would come and eat his liver, and at night the liver would regenerate. So somehow the ancient Greeks knew that the liver could regenerate. So what is a wound? The basis of a wound is an incision, and it's in the surgical wound, it's very clean cut, and we just put a suture and it comes together and there's no gap. So it heals by primary healing usually. So you have a clean incision all the way down to the fascia. We do whatever we have to do in surgery. We put it back together completely so they're opposed, and it heals by primary intention. Now let's say you don't have suture for whatever reason. Usually the biggest reason is you have a dehiscence or you have an infection. Then it heals in another way. It heals from the bottom up. So this whole thing slowly fills up with fibroblasts until it gets to the very top. And that's why when you heal with secondary intention, you have a wider scar. So primary intention, you put these things together and you get a very thin scar. Secondary intention, it heals from the bottom up, and usually it's for infections. So what is the main bulk of healing? It's made out of collagen. So what's collagen? Collagen is the most abundant protein in our body. For mammals, it's 30% of all protein. It gives us the tensile strength of the wound. So the tensile strength of a wound is directly proportionate to the amount of collagen within the wound. And it increases as the collagen cross-links. So the collagen also changes, and there's different types of collagens, and also they become cross-linked. And at 6 weeks, you get about 80% of the strength, and the skin has normal strength at 6 months. So you're mostly healed. That's why we say usually 6 weeks, you're mostly healed. So here's, under the microscope, you can see how the collagen, when it's mature, it's nice and completely in line all together. And here's a fibroblast that created the collagen. This is, I'm not sure what kind of this is. This is some, I'm not sure what tissue this is, but here you can see the alignment of all the collagen. And I know what this is. This is the annulus of a disc. So this is all collagen too, but it's at 60-degree angles. And the reason why the disc has a 60-degree angle is because it has to undergo forces of twisting, and also, and that's why it's at different angles. So this is the collagen formation of inside of a disc, and it gives us the tensile strength. Now there's a lot of collagen. There's all sorts of different types of collagen. In orthopedics, we always talked about type 2 collagen because that's what makes up most of hyaline cartilage, or the cartilage within the knee. When you have a wound, it lays down type 3 collagen, and then as the collagen matures, the fibroblasts mature, they lay down type 1 collagen in the wound. And if you don't have these types of collagens, you have these diseases. So if you don't have type 1 collagen, you get osteogenesis perfecta, Ehlers-Danlos syndrome. So there's many collagens. So what makes collagen? The cell that makes collagen is the fibroblast. So the fibroblast creates the extracellular matrix in the dermis that makes the wounds heal. So let's go over what happens. So you have a skin incision, and the first thing you do is you get a clot. You have to stop the bleeding. So the clot is full of platelets, fibrogen, thrombin, and the fibroblasts start to differentiate and come in there. And when the platelets die, they let off a lot of factors too that cause all these things to happen. So they initiate the process of cells migrating in there, the cells differentiating, the fibroblasts putting down collagen. So again, now you have this fibrin clot, and macrophages, white blood cells come, and then this is within the dermis, and then the fibroblasts start to differentiate and lay down collagen. Then the epidermis, this is the basement membrane. The epidermis starts to grow, sort of like cancer. They proliferate, and they go and they fill where the basement membrane is to cover the wound again. So you epithelialize. So you can just imagine here's an artist's rendition of the clot, and then here's the bottom of the wound, and now the wound's trying to heal itself. So after the initial clot, the next form is granulation. So this is a scar that's granulating. It's beefy red, and that's because it's very vascular. And the endothelial cells are dividing now. You see here, they're migrating to cover this wound. Epithelial cells. There's new capillaries, and underneath in the derma there's fibroplasia where collagen is being laid down. Now this is more mature now. I think it's about 2 weeks, and I'm sure all of us has had something like this. Now the epithelium is slowly growing to cover the wound. This is a large wound now. For us, for those knife incisions we make, the scalpel incision, in 2 weeks that thing's covered. It takes about 2 weeks, don't you think, Doug, for the epithelium to cross the skin edges. So that's why we say in 2 weeks you're pretty much healed. The epithelium is covered if you have a nice wound, if you have a primary wound. So this is artist's rendition of the basement membrane and the epithelium growing over the basement membrane to cover the wound. And then once the wound is covered minimally, then it grows outwards with mitosis, and it makes a thicker epithelium. So what factors are there, and we're going to go all of them, that keep your wound from healing? So age, so we'll just go over them one by one. So nutrition is one. And the problem we have is most of the people that go to surgery have malnutrition, especially the inpatients. Their albumins are low, their proteins are low. So we're starting, behind the 8 ball to begin with. And electively, we should probably be putting people on shakes, especially people who we think don't have good nutrition or something to get their proteins up. Doug, do you have any protocol for nutrition pre-op? We probably should, especially for elderly people.
I have 2 protocols. Every diabetic patient that I operate on post-op gets zinc, vitamin C, and iron. And every person that I do a hip fracture on gets 2 cans of Ensure a day.
Mm-hmm. It's probably good. So like Doug said, there's also vitamins. So vitamin C is what cross-links collagen. And we have our protocols, but we have vitamin C. And without vitamin C, you get scurvy. So if you have horrible scurvy, even old wounds open up. So vitamin C is very important for wound healing. But like Doug said, there's zinc, vitamin A, B6, B1, thiamine, B2, riboflavin.
And I give vitamin C to every patient I have with a wrist fracture.
For cross-linking of collagen, it's probably a good idea. It most certainly can't help. I mean, can't hurt.
Supposedly shows a marked decrease in pain.
Really?
Yeah.
I believe it. So.
And I think it's benign. It's like.
Yeah,
it
can't.
It's a no-brainer.
It can't hurt. Yeah. So low oxygen tension in the tissues also is bad for wound healing, probably for the blood supply and epithelium. And the cases of that are basically the case I can remember is an ankle fracture that was that had poor blood supply to the leg. I fixed the fracture and the wound never healed. And then we worked it up. We found that it had very little blood supply, and then we needed a vascular procedure. So any question, when I used to do extremities, I used to look into that with a vascular consult, especially diabetics. So diabetes, like Doug said, that's a serious problem for wound healing as well. I'll never forget once when I was at university, I had a patient that resected a tumor, and the wound never healed, and her glucose was out of control. Once we got the glucose under control, it took 2 weeks actually to get the glucose under control. The medical team, the wound completely healed. So there's something about diabetes that keeps wounds from healing. I'm not sure. We used to. Someone told me once it's high glucose within the blood system affects the migration of white blood cells. But I'm sure there's many factors. But the diabetics don't heal their wounds, and also they have a higher infection rate. And if you have a diabetic, the diabetes has to be under control for the wound to heal. So it's very critical. Do you have anything to add, Doug? So obesity is another factor. So this is an independent factor, independent of diabetes. And why it is, I'm not sure, but it's been found to be an independent factor for poor wound healing. Immunosuppression is another factor for poor wound healing. And the most common one is patients on prednisone, which we see all the time. So I'm sure it affects the migration of the cells, the fibroblasts. Chronic venous insufficiency. Age is also an independent factor for poor wound healing. And I recall when I used to do research that the human fibroblast could only differentiate in culture 20 times. So there's only so many times that the fibroblasts could differentiate. And I think what happens is the fibroblasts just don't do as well when you're older. And infection is also a risk factor for not healing. This is a wound that had cellulitis. Another risk factor for poor wound healing is infection risk is operative time. So the longer the wound is open, the higher the probability that there's trauma to the wound and also infection. Room traffic is another risk factor. So all these people carry bacteria with them. And interestingly, some people shed more bacteria than others. So trying to decrease the wound room traffic is critical, although it's extremely difficult to stop. It's just no one except for the surgeon. I feel no one except for the surgeon really cares about infection. Do you agree with that, Doug? I mean,
Yep.
People walk in without their masks all the time, and I tell them, "Would you walk in your mother's room if she was having surgery without your mask?" I mean, it's really not right.
I've taken pictures and sent them to the chief of surgery, anesthesia in my room with their mask on, and they
Sometimes,
their nose.
sometimes I think I'm the only person who cares, the
They do
surgeon.
nothing about it.
Yeah, they don't care about infection. So tissue trauma also is bad for wound healing. That's why I try to minimize retractors and anything that can cause trauma. A foreign body is bad for wound healing. The body reacts to the foreign body and causes an inflammatory response that's not coordinated. And hair is a foreign body, so that's why I really want all the hair off the wound, and that's why I usually do it twice in the operating room. If there's any question about hair, I take it off, even if it's like a tiny bit. Smoking is another poor prognostic indicator, probably because of the vascular issues, but it may be nicotine, it may be toxic to the fibroblasts, I'm not sure. Alcoholism is another risk factor for poor wound healing. Tension is also another risk factor. So this wound has a lot of tension on it and swollen. So I'm not sure why tension is a risk factor. There must be some kind of mechanical reason for it.
I thought it's
Doug?
the other way.
Hmm?
I thought it's the other way. Tension.
They go in the other way, yeah.
You know, it's like if you make an incision on an extremity, you know, it heals if you put it lengthwise. If you put it transversely, it doesn't heal because you have tension pulling the wound edges apart.
Yeah, that's what I mean when I say tension. Stress is also an independent factor. So stress affects the immune system. So, I mean, we all know that if we're totally stressed out, we get a cold or a cold sore, etc. The immune system is depressed when someone's stressed. Radiation is a poor prognostic indicator. So usually you don't want wounds irradiated for 2 weeks. And that's common for cancer surgeries. And so in 2 weeks, things are basically, the epithelium's covered, it's mostly healed, and you can go ahead with radiation for cancer and chemotherapy. So a big problem we have is MRSA, methicillin-resistant Staph aureus. This is MRSA. So especially for implants, we screen all our patients with a nasal swab. It's probably the easiest way to see if they're MRSA positive, and then I treat them with Bactroban cream and scrub for a week, and then recheck them. So any questions up to this point? Sorry, I'm going fast, but I have surgery today. So what do I do is I give them chlorhexidine. This is the chlorhexidine soap I give them, and I tell them to wash their surgical site the night before to decrease the flora. And then I wash my hands 5 minutes by the clock. I tell everybody it has to be by the clock. Then the surgical wound, they're shaven in the pre-op area, so there's no hair in the OR. But I almost always have to do it again in the operating room to get some last bits off. And then I have them do this chlorhexidine scrub for 5 minutes, again by the clock, because if you don't look at a clock, you don't do 5 minutes. And then I dry that, and then I use the ChlorPrep, what's this called, paint, and then leave it dry for 3 minutes.
Wait a minute, that is chlorhexidine.
Yeah, paint. I do both. I do the scrub, and then I do the paint.
I thought it was all one.
This is different. This is soap.
Oh, okay.
That's a soap, and then I do a paint.
I got you.
But sometimes you get poor wound healing for whatever reasons. So what do you do with wounds that don't heal? Well, my standard is just wet to dries. So it's very effective. It's cheap, and it just heals from the bottom up. It's labor intensive, but it's good actually because someone's looking at the wound. So I don't like it when they put these things in the wounds and they don't look at it for 2 weeks. I think someone has to keep an eye on it to see if it's getting worse or if it's improving. So the way wet to dry works is the 4x4 just has to be slightly moist. It goes into the wound, basically attaches, and then when you pull it out, it debrides it. It takes away dead tissue, and then slowly the wound contracts. The other thing you have to tell people is don't stuff it too deep or too hard because the skin edges will never come together. So it's just loose. Another option we have is the wound vac, which I've used many times and I think is great. The only problem is people don't like carrying around the little suction device. So it's basically a black sponge that it's just colored black. I don't know why. That sponge that goes,
See the blood on it.
I guess, black, a sponge that goes in, and then you attach a suction device to it, and it contracts the skin edges, and it also removes all the fluid or exudate, and the suction actually helps the wound proliferate to cover itself, and it also removes any exposure to the atmosphere too, so the bacteria doesn't get in as well. So it works very, very well. The only problem is the patient has to carry this little thing around the suction device, and they get irritated. That's it. So any questions about who's going to win Sunday, Ravens or Bengals? Ravens.
Bengals are good.
Bengals are good.
Yeah. Well, we don't know about the Ravens.
Yeah. So any questions or comments about wound healing? Doug?
Keloid.
David?
You mentioned keloid.
Yeah, keloids. Keloid
That's
formers.
excessive hypertrophic scar of the skin.
Yeah.
I think keloids are only on skin. They're not internal, right? Are there such things as internal?
Well, it's definitely
Well,
hypertrophic
you have-
bone healing.
I do
Yeah.
see some patients that
In
have a
the belly,
terrific
you have-
amount of
you
scar.
have adhesions, which are
Yeah.
scars,
I think they have it.
but they don't call it keloid. Keloid is
Right.
usually.
We just call it scar, yeah, when it's
referred
deep.
to hypertrophic skin scar.
Yeah, but I've seen some people a lot more hypertrophic than others. Yeah.
And some of that depends on race. Blacks scar very heavily many times.
Yeah.
Not always, but
More
many
prone to
times.
keloid,
Yeah, a lot more common. Is that it?
Yep.
Thanks for coming, guys. See you next month. Go Ravens.
Where to?